Okay, looks like it maybe has slowed down a little bit. So again, aloha everybody and welcome to the Regional Community Coalition All-Member Call today. We have a lot of great information for you. And today our presenter will be Kyla Newland and Ray as we call him. He's our analytics person for the Partnership in Community Health, along with Liam Hettinger. And today, Lori Shikoyak is going to be our presenter and get us started. So go ahead, Lori, take it away.
Thank you so much, Mark, and welcome everybody. What a great group we have today. I'm so glad you could join us for our Regional Care Transitions Coalition call. We do have a great day planned for you today. Next slide, please. As we get started, just a couple of housekeeping items. When we do get a big group together and we're on Zoom, something that will be really helpful for all of us you will keep your mics muted during the presentation. But we do want you to interact, so it would be great if you want to enter a question or a comment into the chat box. Please feel free to do so and share your experience with this time in our group chat. And there will be time for questions, at which time you would be able to go ahead and pull your mic off mute. Next slide, please. And we'd also appreciate it, and I see some people have already started, so thank you. Some of you are very used to the order in our presentation. If you guys wouldn't mind sharing who you are in the chat, that would be great. Just your name, where you're from, what organization you're with. So if you don't know me, by the way, my name is Lori Shikoyak. I am an account manager here in the great state of Alaska, and I'm happy to be with you today. We have a great presentation plan. So as everybody's chatting in their information, Mary, if we could go to the next slide, please. So Mark already mentioned we are going to hear from two great people today as presenters. Kyla Newland, who is a pharmacist here with Mountain Pacific, will be sharing first, and we will also get a great analytics update from Ray Tupling. So next slide, please. And at this time, we're going to go ahead and have Kyla present first. We usually have a little bit more to our beginning order. We're changing things up just a little bit for today. We are actually going to dive right into a great presentation by her on vaccine updates and medications for opioid use disorder. Next slide, please. So Kyla, I'm going to go ahead and turn the time over to you. Thank you so much for presenting today.
Thank you, Lori, and welcome everybody. I am also in the great state of Alaska, and I'm actually going to talk not specifically about medications for opioid use disorder, but just give kind of a general update of the data that we're seeing in all of our region related to overdose rates and substances involved in those. But to start us off, a reminder on the next slide about the upcoming Drug Take Back Day on October 28th. So coming up just this weekend, there are multiple locations in all of our states, and Lori's going to share links in the chat today, and she'll put this link where you can find a location near you. So this event happens twice a year, and it's always a good time to go through your medicine cabinet and clear out medications that are either discontinued or expired, just to make sure they don't get in the wrong hands. We can go to the next slide. So first, I just wanted to look at each of our states and what's going on with overdoses. It's become pretty clear recently, and a lot of discussion here in Alaska, I know, and in all of our states, that the overdoses are not just involving one drug, but in the majority of cases, up to 3 or more drugs. So if you look at the most current data from Alaska, of all the overdose deaths between 2018 and 2022, 58% involved drugs from more than one narcotic, sedative, or psychotropic drug category, and 32% involve 3 or more. And what we're seeing as kind of a general trend is we saw this kind of opioid curve going up, and now primarily fentanyl being responsible for those overdoses. But we're seeing psychostimulants and stimulant medications, different derivatives, really kind of climbing up with the opioids. So we're seeing kind of that dual overdose, and then in a lot of the cases, there's other substances as well. So just wanted to kind of bring that all to the front line, because we don't have any way to treat any data driven therapy for stimulant use disorder. So this is kind of becoming an up and coming topic, and something that we'll be looking for more information. So you can see the Alaska, and then I grabbed a chart from Wyoming, and we can go to the next slide, where I did get some data from Montana as well, and they are seeing this huge increase, 131% increase in psychostimulant overdoses, and only a 63% in opioids. So it's even higher, climbing at a higher rate in the Montana data. And then I wasn't able to get the most current data for Hawaii, but this is what I found from 2020. And we actually hadn't seen a lot of opioid overdoses in Hawaii previously, but more methamphetamine or stimulants, which this chart shows. But we are seeing kind of a similar trend, as you'll see, with the opioids going up now, in alignment with this, the stimulant drugs. We can go to the next slide. So just a couple of resources for you if you're looking at doing any work with opioids in your communities or in your facility or in your coalitions. These are a couple of nice tools if you want to look at starting an opioid stewardship program. One of them is from PharMerica, so more focused on a long-term care. And then the other one is from the American Hospital Association. We can go to the next slide. And then just some upcoming events, and I apologize. The top event actually already happened today, and I was able to attend. It was talking about xylazine. It was a really good opportunity. So I will make sure that we send that out once the recording is available to everybody, because I guess I didn't realize it was going to be before this call today. And then a series that Mountain Pacific is collaborating with some other QIOs is started in September. So we've had two sessions, and that will go all the way through until June. And that's really looking at those medications for opioid use disorder and treatment across all of the care settings. So feel free to sign up for that. It's really good information, a lot of really good speakers there as well. We recently had a medication-assisted treatment conference here in Alaska, and I've put the link here to those recordings and slide sets as well. That was very, very insightful information. And then Mountain Pacific has a podcast that we are rolling out new episodes every month called Breaking Barriers in Rural Health. So take a look at that. Go to the next slide. So just shifting gears a little bit here, and I'm going to talk about vaccinations. I thought this was a really nice quote from one of the, I guess, blogger folks that I follow. Their local epidemiologists, Caitlin and Caitlin, and they put out really good information with updated vaccine resources and information on I think a weekly basis. So I like this quote because we have 3 fall respiratory viruses that we can cover with vaccines, which is very exciting. We can go to the next slide. So the first of those, and I'm sure folks have heard about this, is the new RSV vaccines. So we know that RSV can be most detrimental to our young population, so our babies, and also our older population, and also folks that have conditions such as COPD, diabetes, heart failure. Anybody with a weakened immune system are people that are at higher risk for RSV. So it's very exciting that we've got a vaccine this year to protect folks. We can go to the next slide. So the CDC approved the RSV, 2 different RSV vaccines this fall, and they are recommending it for all patients 60 and older, based on a decision-making process that they would have with their provider. So they put that in there, basically saying that they should have a discussion with their provider if they're 60 or older. They didn't say they must get the vaccine, but they should definitely consider it, especially if they're one of those patients that has those higher risk factors that I mentioned. So both the vaccines were very efficacious. They are recommending get it as soon as possible. I know it's available at local pharmacies already, and I think it's being widely distributed. So whoever does vaccines in your community, you can call and ask if they have RSV vaccine. And we don't have right now, it's a 1 dose. So we don't have any information on if there'll be booster doses needed, but that could be to come in the future as we get more data. We'll go to the next slide. So these are the 2 vaccines, a Brisvo and a Rexv. They are both administered IM. They have a similar side effect profile with kind of the normal side effects that you would expect from vaccines: fatigue, headache, pain at injection site, muscle pain. In exception, a Rexv had a higher percentage of injection site pain, which is interesting compared to a Brisvo. But one of the things I noticed that might be attributable to making that a lot higher is that the adjuvant that they use in a Rexv is the same one that they use in the shingles vaccine, which typically does cause higher percentage of these injection site reactions. So it's just interesting. I'm not saying that's scientifically proven, but I did note that, and maybe that's the cause for the difference. We can go to the next slide. Oh, and I will mention, as far as side effects, like severe side effects that I didn't have on that slide, they did see some cases of Guillain-Barré syndrome, which is something that they do think sometimes vaccines can trigger. It's a neurological disorder, but that was not conclusive enough because they didn't have enough patients to power the fact that RSV vaccine did cause those cases, and so more to come on that potentially. So in addition to the adult vaccines, we also have pediatric monoclonal antibody that got approved. So moving forward, 1 dose is recommended for all infants less than 8 months of age in going into their first season of RSV, which is going to be in alignment with our flu and fall respiratory virus season. And then for more compromised infants, they do recommend it up to a higher age as well. We can go to the next slide. So additionally, they did approve an RSV vaccine for folks in pregnancy as well to help protect the babies. So it's not clear to me yet, since these both came out kind of in a row, if a mother gets the vaccine, if her infant should also get the monoclonal antibody. And if anybody has any additional information on that, I would love to hear. Basically, it was very effective, reducing hospitalization by 57% in the first 6 months of life in these women who did receive the vaccine. And also of note, the only vaccine that was approved was a Brisvo. So Rexv is not approved for these pregnant women just because they didn't study it, and maybe eventually they will. We can go to the next slide. So pneumonia. Pneumonia is very prevalent. About 1 million adults in the US see care in hospitalization for pneumonia every year, and 50,000 of these people will actually die from pneumonia. And we have good vaccines. We have several newer vaccines that came out, and so our recommendations changed in the last year. And I will talk just a little bit about some resources that can help you determine which vaccine would be most appropriate for you. And a nice top 20 pneumonia facts sheet as well. Go to the next slide. So I really like this application, and you can also do it as on your desktop if you just Google Pneumorex Vax Advisor. It is a tool where you can put in specifics of a patient, their age, their risk factors, their previous doses of any kind of pneumonia vaccine, and it will tell you which additional vaccines they may be appropriate to get. So if you're not already using it, I would highly encourage you to use this tool, because it can get confusing, especially with the two new products that came out. If people have previously had a pneumonia vaccine, should they get the new one? Do they need to get the new one? What's the timing? And kind of all of those little logistic items. We can go to the next slide. So this is something that they put out from the CDC that shows how you decide. So if someone has already had one of the previously available vaccines, which were Pneumovax and Prevnar, and should they get the PCV20, which is one of the new ones. So this is a guide that kind of goes through and says, okay, let's look at these risk factors. Let's look at when you got your last vaccine, and let's make a decision on whether we should give you this new vaccine. You can go to the next slide. So moving on here to COVID. This is our most current strain that's circulating, and that's going to be the EG5 Omicron variant. If folks will recall, when they came out with the new fall COVID formulation, it covers at that time, which was the prevalent strain XBB 1.5, which you'll see now only accounts for about 2% of cases. But the good news is that when they looked at the new monovalent vaccine that is recommended this fall, they're seeing really good coverage still against this EG5 strain. And I think I have info about that on the next slide. Yeah, so this was Moderna and their product coming out and saying that they are seeing good coverage against the currently circulating strains. Pfizer put out a similar statement, and now we have Novavax as well that just got approved for the fall formulation. We can go to the next slide. So this is a really nice resource. This gets updated every month, and this is through one of my favorite websites, immunize.org, and it basically has all the information that you need to know about COVID vaccine recommendations, COVID vaccine drug therapy, what the products are, how to administer them, how to store them. And this is just a screenshot of the top, but it is a nice comprehensive guide. And like I said, they do update it monthly, which is nice, as we see things changing frequently in this space. You can go to the next slide. So this is a nice infographic as well that shows you what the vials actually look like and what your dosing regimen would be based on your age, as you can see on the left-hand side. So this one's the one for like just a general patient who's not moderately or severely immunocompromised, but there's also another one that's appropriate for folks that might be immunocompromised. So I'd encourage you to check those out. You can go to the next slide. So another program that they rolled out when the COVID vaccines went from being federally provided free to everyone to being commercially available, they have this Bridge to Access program that folks who are uninsured or underinsured, or if their insurance for some reason wasn't wanting to cover it, or maybe it had to apply to a deductible, they can get the vaccine for free. And the two pharmacies that are participating in this program are CVS and Walgreens. So if you go to their website, you can sort, it'll be the Find a COVID Vaccine website. You can sort out by providers that are participating in this program. And there are other folks that are participating as well, beyond pharmacies, like some public health departments And I think I even saw a couple clinics on the Alaska list. So if you've got patients that want to get the vaccine and for some reason are being asked to pay for it, I would direct them in this direction. Go to the next slide. So flu season, we're in it. Everyone should hopefully be getting their vaccine by the end of October. And flu does have a significant burden as far as deaths, hospitalizations, and illnesses, as you can see by this chart here. You can go to the next slide. So basically, our recommendations this year haven't changed really since last year. Everybody 6 months and older should get a flu vaccine. There is a preferential recommendation for folks that are 65 and older to get one of these products, the Fluzone HD, Flu Add, or Flu Block, because they have shown a higher percentage of efficacy for that older population. All the formulas are going to be quadrivalent, so they're going to have the 4 strains of flu, and most are thimerosal free, and 21% of flu vaccines will be egg free for this year. And on the next slide, I believe I have a list of all of them. And I'm sorry, the top of this chart got cut off, but this shows the dose. This shows if it does have thimerosal, how much it has, which is really a trace amount. And then the age range that the products are approved for, and also the billing codes. And this is also from immunize.org, my favorite website. Go to the next site. So we are seeing good results from the flu vaccine in the Southern Hemisphere so far, which is a good sign for coverage here. They have reduced the risk for influenza-associated hospitalizations by 52%. So that's a pretty high percentage and good information as we move into our season here, compared to the South. As we'll recall, they get an earlier flu season than we do. We can go to the next slide. This is a chart from your local epidemiologist that I really like. It shows all of our respiratory viruses for the fall and who should get them and how effective they are, and kind of the dosing timing. So I like this because it's a nice visual. Go to the next slide. And once again, you can order free COVID tests. I actually just got mine yesterday. So if you want to have those for your house, go ahead and order them, and they're free. Go to the next slide. Just going to highlight a couple resources that we put out this fall, with one with a football theme and one with a Halloween theme, with myths and facts about our vaccines, not specifically just COVID, but also including some myths and facts about flu and pneumonia vaccine. So the next slide, I believe, has the, I really like this one. I like the pictures and I like the little on there at the top. So this could be something that you could distribute in your communities. Go to the next slide. And this nice pneumonia handout. When we were looking at kind of doing a campaign for pneumonia vaccine, there wasn't like just one nice kind of concise patient-facing document that addressed pneumonia. And so we created this in collaboration with our Patient and Family Advisory Committee, which was really cool. You'll see up in the right-hand corner, they put their stamp of approval, and they really helped us make this so it would be the most simplified it could be and the most kind of visually appealing to folks to get the information out. We'll go to the next slide. So this question has come up, I know, with some facilities here in Alaska and some partners, just on how long do these vaccines last. So we know the influenza vaccine lasts about 6 months. That's why we try to get it right at the beginning of flu season, by the end of October, and that'll last us kind of through our spring and our most kind of peak time of flu. For RSV, we don't know on RSV yet. So as I mentioned earlier, since it's a new vaccine, they did study it through 2 fall respiratory seasons. So we know probably at least 2 years, but we will still have to see on that one. Pneumonia, this one can get tricky, as I mentioned earlier, because of the different available products and the fact that folks may have gotten an older product, and should they get a newer one? Is it better? Does it cover more strains? So one misconception that I will say is that you should get it every 5 years, especially after age 65. With the new recommendations, if you are 65, you should get 1 dose of pneumonia vaccine if you get the PCV20. If your provider, or if for some reason you can't get the PCV20, then you do have to get 2 doses. But after that, there's no need to repeat that vaccine every 5 years. And then COVID-19, we're thinking it probably has a duration of similar to the flu shot, since it sounds like we're going to have a new vaccine every kind of fall season. So hypothetically, probably about 6 months, but could be a little bit more or less. We're still kind of waiting on all the data for that. And go to the next slide. So this is my last slide, and I just wanted to put this in here because I think it's really important as healthcare professionals that we think about this when we're making our personal decisions as to whether we should get vaccinated or not. And so I took just a couple quotes. I'm sure you all are familiar with the Hippocratic Oath. I know that it does kind of specifically relate to physicians, but I think it should be universal across all folks who are taking care of patients, that really we should prevent disease whenever we can, first do no harm, and take this as our moral responsibility as healthcare providers to get ourselves vaccinated so that we can protect our communities. And I think that was my last slide. I think I have a resources. Yeah, this is just some nice resources. A webinar from the CDC that kind of outlined all of our respiratory stuff this fall. Updates on the circulating viruses and data. And then there's a really nice series here in Alaska that's open to folks in all the region, of course, that goes a vaccine echo that's every month. And they have really good information on there as well. And then this influenza vaccination honor roll is another thing through immunize.org, my favorite website for resources, where you can honor different facilities, or I think there's hospitals, clinics, nursing homes, anybody that mandates flu vaccine for their staff can become recognized in this honor roll. So that can be kind of a nice thing to be able to recognize folks in different institutions. And I think that's all. Does anybody have questions? Thank you, Lori, for putting all those links in there.
Yes, I was just going to mention that as you went along, I tried to put the links into the chat for everyone. So feel free to pull any of those off, and they will come with the slide presentation later. All right, and Kyla, thank you again for sharing. Do we have any questions? Any additional questions for Kyla? Okay. If you think of any, don't hesitate to put those in the chat, and we'll move along here with our presentation. So just getting a little pulse check here. As a reminder, Mountain Pacific is here to serve you. We want to collaborate and be your partners, and we work with you in so many ways. Please reach out and let us know additional ways we can help support you. Maybe it's in our regular meetings, coalition meetings, or other activities going on that we could help you. Please don't hesitate to reach out to the local person in your state that you work with. And then as a reminder, you know, decades ago, people stayed in the same job for like their whole career. It seemed like in my grandparents' era, that was certainly the case. But now we all move around a lot, and people change roles and positions, and move. And so if you have changes, please let us know, updated member names and their contact information, so we have the most current person who's working in that position so that we can best assist everyone. And then let us know. We want to be sure we identify the most important areas of focus in your community. So if you're curious about something or want to know more, I know in Alaska, for example, we're doing a deep dive on some of our readmission data, looking at that to help tease out some things that may help us prevent more readmissions in Alaska. We are here to help you with that as well. And then just a reminder for all of you that we do have the little participation agreement that we need all of you to be a part of as we share data with you. You can find that on our website. It literally, if you just open it, you can sign it right online. It's not a big deal. And then last but not least, of course, there is the all member meeting, January 23rd, 2024. We'll come back to that at the end of the presentation. Next slide, please. And here we have listed the goals of all of our coalitions in our states. So we do want to reduce our opioid adverse events and deaths. We focus on chronic disease management. And we also focus on care coordination across settings. Another focus is emergency preparedness plans and also immunizations. And we heard from some of that already from Kyla today, addressing few of those areas. Next slide, please. And at this time, I'd like to introduce Ray Tupling, who is our analytic team lead. He's a fabulous data guy. I don't know how else to put it, but you know, it takes a special kind of person to be that, and Ray is brilliant at it. So I'm really happy to introduce him today, and he's going to share some data information with us. So Ray, I'll turn the time over to you.
All right, sounds good. First of all, thank you for having me. As I said, my name's Ray. I'm part of the analytics team here at Mountain Pacific. I will share my screen in just a moment here. Let me make sure I get the correct screen up. So today I'm going to be presenting some admissions and readmissions data among the fee-for-service beneficiaries across our 4 states. So what we're looking at here is the admissions rate per 1,000 beneficiary years for all 4 of our states in the Pacific Territories. Over on the left here, we've got Q1 of 2020 to give us a little bit of insight as to what things looked like pre-COVID. And then all the way over here on the right is our most current time period through Q2 of 2023. So as you can see, from Q4 of 2022, we have been trending up as far as overall admissions throughout our 4 states. And we'll dive a little bit deeper here, and we'll look at what's driving those admissions. And we're going to break them down by our diagnosis code groupings. So again, we're looking at quarterly data. It's from Q1 2020 to Q2 2023. The most frequently occurring diagnosis code grouping that we see is actually hypertension. And I should note that these hypertension ICD-10 codes could appear at any position on the claim. So again, hypertension is the most frequently occurring, followed by chronic kidney disease, diabetes, and heart failure. I was going to point out one of our state differences. So if we focus in on Hawaii, we'll see that the most frequently occurring diagnosis code is CKD, and it's far and away the most frequently occurring among these groups. Whereas if we look at Montana, our second most populous state, hypertension takes the cake here. So there are definitely some nuances across all of our 4 states, and I'm sure you'll agree it probably gets even more minute when you go from even cities to more rural areas. But that's what we're seeing on the landscape as far as admissions. Let's go into readmission rates now. And again, these are 30-day readmissions from Q1 2020 to Q2 2023 among the fee-for-service beneficiaries. Again, pre-COVID, we started at about 1.8 readmissions per 1,000 beneficiary years. We have since climbed close to that. We're currently at about 1.67 30-day readmissions per 1,000 beneficiary years. And again, we're on that upward trajectory from Q4 2022 onward. And then breaking these down by the diagnosis code groupings, it'll come as no surprise that chronic kidney disease is again very frequently occurring, followed by diabetes, hypertension, and heart failure. And one concerning thing that we're starting to notice is from Q4 2022, nearly all of these are on an upward trajectory. It fits with our increased readmission rate, but it also says that there are, it says there's some chronic issues out there, whether it's hypertension, chronic kidney disease, and diabetes. So really this covers the gamut as far as care coordination, chronic disease management. So yeah, if you have any comments, anything you'd like to see, questions, feel free to put it in chat or come off mute. Other than that, that's all I've got.
Ray, thank you so much. What questions do we have on the data for Ray? Any questions? Welcome to put it in chat or come off mute if you would like.
All right. If there's nothing, I'll stop sharing and hand it back to you, Lori.
Okay, sounds good. And as Mary is pulling up the next slide, I believe on our next slide, we have a polling question. So Mary, could we go ahead and launch our polling question 1? So our polling question today, one of our 2 polling questions asks, when assessing a patient's need to stay in a facility or be sent to a hospital, your decision-making process includes the medical director, family members of the patient, the staff, or all of the above. Great. A lot of you are answering that and responding to the polling question. Thank you so much for taking a moment to do that. I'm going to give it a few more seconds. And then after that, we'll have one more polling question. Great. We've got a few of you still answering, it looks like. So I'm going to go ahead and just give you a couple more seconds there. Thank you very much. We have an overwhelming response to this question of all of the above. I love that. About 93 or 4% of you agree all of the above. Awesome. Okay, let's go ahead and end that poll if we could, Mary. And can we share those results? Maybe I could share those results so you guys can see those. And so as I said, the vast majority of you said all of the above. We have one more polling question, and that is, does your community have readily available access to naloxone? I know Kyla, I believe, had to hop off, but she did talk a little bit about adverse drug events, and naloxone is so important. And our question here asks if we have it available and where it's available. So if it's available to all patients, providers, caregivers, or if there's still some gaps or barriers to access, or if you have no access. Great. Thank you guys again for being willing to answer the poll. This is awesome. I'm going to give you guys several more seconds to answer. Great. We've got several of you still answering the poll. This is great. And as we're doing that, Ray, thank you for responding to Danielle, who asked about accessing that data. I appreciate that. Okay, great. It looks like we have a lot who've responded to the poll, and I'm not seeing many more answers come in here. Looks like we're about done. Let's go ahead and end that poll, Mary. And then I'm going to go ahead and share these results. It's quite interesting. I just shared. Great. So it's really split. The majority of people said there's still some gaps and barriers to access. And then the next most common question, which I'm happy to see about a third of you say that everyone or all patients, providers, and caregivers have access. So it looks like we have some room for improvement in that section. I'll be sure to give that feedback to Kyla as well. And I know she mentioned the xylazine, and she's going to kill me if she would hear that translation of how that word is pronounced. But we also know that with more than one opioid being used at a time, sometimes naloxone is not working, and so that additional medication may be necessary. And so I hope we start getting that rolled out to some of our communities very soon as well. Okay, Mary, if we could stop sharing and then move on to the next slide, please. Okay, so just some upcoming events we do want to mention. Every week we host a series on Wednesdays called It's Worth a Shot. And it's a virtual series that's located here. We'll get that link to you. And it's awesome. I love it. It reminds me of a TED Talk, if you're familiar with those. It addresses a variety of topics, everything from vaccines to infection prevention and control to opioids, a whole slew of topics that we hope are relevant to you as you work in your healthcare setting. And then the next thing, and I believe that Kyla mentioned this during her presentation, and that was the podcast that's going on, which is awesome. You know, if I'm going out for a walk, it's nice to be able to just plop on a podcast and listen to it as I walk. I don't know how or when you prefer to listen to your podcast, but get tuned in. This is an excellent one, and you'll learn a lot of great information. So I encourage you to go ahead and listen to that. I believe it happens about once a month for a new episode to occur. Sorry, and last but not least on this slide, our next regional meeting is going to occur on January 23rd. Gosh, is 2024 really coming up that quickly? Oh my goodness. There is a link for the registration there. But if you're registered for this one, you will be, I believe it's for the series, you should be already registered for the next one. But if you have other staff or colleagues that you know would be interested in this call that are part of our regional coalition, please don't hesitate to share that with them. We would love to have them join us. Of note, the time does change in most of our states for the next quarterly meeting. So the times may be a little different for some of us than this meeting, just because of the time change in November. Or sorry, yes, in November. So next slide, please. And here's just a link to some general references and resources for you that may be of use. And please feel free to collect those. Thank you so much for putting those in the chat, Mary. I thank you for that. So feel free to download those links and utilize the resources. Next slide, please. I think today when we set up our presentation, we were maybe concerned we could go over time, and I'm happy to say we're doing really well. We are, if you have questions or things that you think of after, Mark Mirabella is our regional lead for all of our states and our coalitions, our community coalitions. Here's his information. Please don't hesitate to reach out after this if you have a question or need a resource. And at this time, because we do have just a few minutes, I want to put it out there again. Are there any questions or comments that came up today? How many of you guys are going to dig into your medicine cabinets? That DEA date reminded me that it's coming up this weekend, the National Take Back Day. And I was sharing this, I think, with my coalition group last week. Recently, I had cleaned out my mom's house, and I was going through a lot of her medications because as a nurse, you know, we're all like, save what you can, right? But anyone want to hazard a guess what the oldest medication I found was, what the expiration date was, like how far it was expired? And I'll just say, guess in years. Anybody want to hazard a guess? Oh, Larissa says 5 years. Keep going. Anyone else want to hazard a guess on that? Oh, Holly, I love that. Tylenol 1998. 10, 15, getting a lot of good answers here in chat. I kid you not, it was more than 20 years expired. It was crazy. So Holly, you were pretty darn close there. So it just goes to show you that, especially in our parents' house or other, homes, if we're working with family members that may have stored things for a while, take an eye on those. Some of our medications can become quite toxic after years. And so we need to respect those expiration dates and be aware of those. I need to finish going through all my stuff. I was ashamed a few years ago when I found some very expired stuff and I got rid of it. But yeah, I need to dust off some of those corners that I don't look at very often and make sure. So take time to do that. Holly says, I know, my grandma's. Yep. Always a great thing to remember. So one last final reminder, if you guys haven't gotten your respiratory vaccines yet, they should be available in all of our states and regions. Reach out into your local communities, whether that's a pharmacy, a primary care provider, or you're working with your local organization where you work to get vaccinated. Get that done. It's a great time to do it. It's one tool in the toolkit to keep us healthy from a respiratory season during this upcoming respiratory season. There you go. So great. Next slide, please.
Hey, Lori.
Hey.
This is
Yes.
Jamie out of Montana. So
Hi,
I
Jamie.
recently read a article about a good way to prevent dementia and Alzheimer's is
Ooh, please share
to do some sort of low impact activity like taking your walk and learning something new. So whether it's listening to a podcast or having a discussion with a friend about something new that you've learned. So that podcast is a great idea for not only new information, but for helping keep your brain healthy.
I love it. Thank you for sharing that, Jamie. That's perfect. Perfect. Woohoo. Anita asked in chat, will DEA take back expired EpiPens? Yes, they will, Anita. Check with your local source, but for the most part, that's what's really nice about the take back is they'll take everything from a bottle to a vial to our things like EpiPens. Yes, they will. Old creams. Not just medication bottles. We tend to think of that when we think of medications, but they do come in a lot of forms, and it is really nice. One of the first times we did this in the community I'm in Kenai, Alaska, it was amazing how many boxes they had to load it onto like a semi truck that we collected in our area. Like it was shocking. And now that it's more in place every year, of course, numbers gotten better. Some facilities have chosen to do this too. So you may work with your local, in-house if you have a pharmacy section, and they too maybe they also can give back their expired medications. And Jamie also chatted in, don't forget about the benefits of sunshine and fresh air. Yes, as you're out there taking your walk and maybe with someone with Alzheimer's and they're listening to that podcast, it is a great way. It has so many benefits. So great. Danielle gave you a nice compliment there. She says, thanks for sharing, Jamie. Very true. Any other questions or comments about our presentation today? As a reminder, thank you, Mary, for putting that into chat again. There's a link to evaluate today's presentation. We would really appreciate the feedback. It helps us. We want to make sure we're meeting your needs and supporting you effectively. And so we would love some feedback. So please take a moment and click on that link and complete the evaluation for today. And I don't see any more questions at this time in chat. Mark, I'm going to see if you have any last words of wisdom for us and to close this out.
I don't know about wisdom, but we do have some words. Thank you all for attending. We really appreciate these all-member meetings for all the information that we can gather. And as Lori said, please fill out the valuation, anything that you give to us that we can add into this, we're looking forward to. And hui ho, until we meet again in January. Thank you all for being part of this group. Aloha.